Hi everyone, so welcome to our Greater Manchester Women's Health Showcase, and thank you to all the team that have made this happen. It's our first webinar on a great series of webinars that will culminate in face-to-face events, but most importantly, this is on International Women's Day, and so a very warm welcome to you all, and so grateful that you'll be joining us on our journey. We're going to be discussing those pressing issues in women's health, from inequalities and social determinants to reproductive and maternal well-being, menopause, pelvic health, chronic disease, cancer, and finally health policy and prevention. Just some quick housekeeping. Please do keep on mute with your cameras off. Please could you use the chat function to ask any questions, and please let us know if you have any issues with this being recorded and being added to YouTube. The speakers have very kindly agreed to keep to time, and I'll be using the hands up button to give a 1-minute warning. And we will take all questions from you to each of our speakers after they've all presented. So each week we'll showcase the fabulous and incredible work that's happening here in Greater Manchester, the research and innovation that's already changing lives and shaping better care for women in our communities and beyond. It's more about just the research, it's about that influence and action, and it's about equity, and most importantly, it's about not leaving anyone behind. In today's session, we will be focusing on women's health inequalities and the social determinants of health. We've got our webinars for all the future events here, and each of these come up with an Eventbrite that will allow you to register for each of the events. So for today's session, we will be focusing on the incredible panel of speakers, all of whom bring vital insights into different aspects of women's health and health inequalities. As a Professor of Public Health and Epidemiology here at the University of Manchester, this has been my passion for over 25 years, and so pleased to see so many of you joining us on this webinar, and also friends and new friends that are going to be our speakers today. So first of all, we're going to start with Dr. Omolade Allen, who will be exploring the role of faith as a social determinant of women's health. Her work helps us understand how spiritual and community networks can bridge gaps in health access and support. We then have Gemma Spears, who will take us into the world of unpaid care, shining a light on how this often invisible responsibility overwhelmingly is taken on by women, and its impacts on health and well-being. She'll show why unpaid care must be recognised as a public health concern. Then we'll be joined by Liz Thomas, who will share the story behind putting homeless women at the centre of a women's health hub. This is a powerful reminder of what can happen when we listen and collaborate. And then finally, we're very pleased to welcome Kirsty Dix and Philippa Wynne, who present their important work, Still Sick of It, highlighting those persistent health inequalities affecting deaf women. Their research challenges us to do better. And when it comes to hearing health, inclusion and accessibility in all parts of healthcare. These are stories of the lived experience, deep listening and understanding, thinking about how we change systems, hearts and minds. I'm so glad that you're all here to begin our journey together and to share our stories and be part of the conversation. Therefore, I'd ask you all to please make full use of the question and answer session after each of our presenters have spoken at the end of the session. Please do post in the chat. For most of you, this will be in the bar at the bottom, and we will go through each of your questions as time allows. So with that note, I'd like to kindly ask Omolade to share her presentation, and Mike, if you could do the spotlighting so we can make sure we see Omolade in her presentation. But thank you all. Thanks, Omolade. Over to you.
Right. Good afternoon, everyone. And it's been a very lovely day. I'm very happy to be here to present my work. And today I am going to be talking about how we can bridge the gap. Basically, I'm going to focus on faith as a social determinant of women's health. And I would obviously highlight some of the evidence from my work to support this presentation. I'm a lecturer in global health research. I'm based within the Division of Medical Education and School of Medical Sciences at the University of Manchester. Now, in terms of what I'm going to talk about today, I am going to be looking at what we know, and specifically, I'm going to also talk about social capital and faith-based support. And then I would look at evidence from my research on domestic abuse within ethnic minority women population to talk about some of the challenges that exist. And then, of course, I'm going to tell you about some of the impact activities we have planned as a follow-on on some of the research we've done in this space. Now, we know that health inequalities persist across all domains for everyone, but specifically women are significantly affected. Within that broad group of women, we know that there is a higher burden on ethnic minority women due to several factors. And we also know that policy responses often miss the culturally rooted support networks that many ethnic minority women rely on. And while some of the challenges that ethnic minority women experience are not unique to them, we have existing evidence obviously that shows that for specific subpopulations within the women group, things are challenging, especially if they experience additional health issues beyond just being a woman. Now, in terms of what we know, there is existing evidence, of course, that shows that social capital within faith-based organizations and groups is something that is very important. So we have empirical evidence that shows and confirms that within faith-based organizations and groups, they offer safety, trust, and culturally resonant support for women. And we also know that, especially with respect to either domestic abuse or even breast cancer and some of the life-limiting health issues, that leaders are contacted first before statutory services. And we also know that depending on where women were socialized, if their country of birth and their country of origin, it could also affect how they take up existing statutory services. Now, what we also know is that these networks, so the faith-based organizations, the community groups, are part of women's lived experience. They are part of their lived environment, and they should be recognized as frontline health partners. Now, there is a depth of information, of course, on how to engage effectively with these groups, and that's an area that my work has been highlighting for the last several years. Now, I have put up here 2 key research papers from my previous work that would be the basis for today's presentation. Now, we know based on one of the work that I've published in the past that when it comes to domestic abuse, especially within Nigerian women in the UK, they disclose their abuse first to their faith community. So there is a very heavy emphasis on faith beliefs, religious affiliations, the support they have, and how that actually helped them with the coping strategies for the abuse. Now, we also know that that is not holistic in its approach because for some of these women, they do not have access to the full picture. Based on evidence that we have from research, some of the support that women receive when they approach faith groups for help is usually very heavily focused on theological interpretations and perspective, and that exclude seeking help from outside of the community. And a systematic literature review that we published earlier on also show that within ethnic minority groups, things like immigration status, stigma, statutory, structural racism, and institutional mistrust are major barriers to help seeking. And these are things that we know already because we have existing evidence of these things happening. Now, in terms of what we need to do, I'm sure that some of you have been working in this space, either with ethnic minority women or even with voluntary sector organizations, and the policy recommendations have been the same. And so I'm just reiterating what we already know with respect to the fact that we need to continue to integrate voluntary community faith and social enterprise actors into health systems planning and early intervention strategies. And these are things that we have been saying based on research evidence. It is not enough to just tell people at the last minute that you need to do something. We need to engage them from the beginning just because it's now established in literature that they are key actors in the way women, especially ethnic minority women, seek help for help. Now, something that also comes across really strongly is the lack of funding for grassroots faith-based organizations. And this is because some of these grassroots organizations are volunteer-led, and even with some of the churches and the mosque and the temples, they also are working on volunteers. Maybe they have a few paid staff members, but majority of the people that go there or work with them are volunteers. And it's very challenging for them to be able to engage in public health, education, and promotion initiatives if they do not have funding to run some of the programs. So it is very important that we begin to diversify our engagement beyond the little groups that we work with, the ones we have existing relationships with. We need to make sure that we are engaging with more grassroots organizations, and that would require obviously funding for them to be able to do more public health promotion and education events. And I think it's also very important, especially as we have research evidence to confirm it now, that we need to recognize social capital as a core component in health equity approaches. Based on evidence we have in the UK, there's little emphasis on the role of the importance of social capital within faith communities when it comes to supporting the health of women. And I think it's very important for us to have this as and a very big approach that we want to focus on. Now, in terms of what we're doing about things, as Arpana mentioned, it's not enough to just do research. We want to extend our research findings and engage in action-oriented activities, basically. So we have 2 events coming up in July. The first is part of the Healthier Futures Fortnight. And so I am hosting a research cafe event on the 2nd of July. And this would be an opportunity for us to host an exhibition. So I'm currently working with an artist in residence that would take some of the findings from the work of women and communicate in the help to explore, and we would use that to have a dialogue and conversation as part of the Research Cafe experience. And on the 30th of July, we're going to have roundtable, facility discussion, commitment to embed pathways, because it just goes beyond saying we need to do something about it. We're willing to have a shift in policy discussions, and so we have these 2 events at 2 months. Now, in terms of my closing reflections, I want to reiterate that women live within rich networks of support, and this can be appropriately utilized to address persistent health inequalities. I believe that we do not do enough to engage with these rich networks. And I know that for some of us, we are doing something already, but we need to have a systemic approach. We need to have a system-wide approach to addressing inequalities and working with these networks that women live within. Faith organizations are not peripheral. They are very central to achieving health equity and reducing health inequality. And I always say this, for some women, if they have a faith affiliation, they will either go to church or go to the temple or go to the mosque at least once a week, and they may not see their GP in 5 years. And so that provides for us a vehicle, an opportunity to actually engage with them as core actors in improving women's health and reducing health inequality. And finally, we need to bridge trust. There is need for us to have trust between the faith-based organization and existing statutory services. And for us to be able to do this, we need to be able to develop co-design pathways that will help us to reduce delays and inequalities in healthcare for women, because we have existing evidence that shows that a woman who continues to go to church, for example, and ask for prayers for things and do not present early to healthcare services may have poorer health outcome just because of the delay in presentation. And there's already established and countless literature on this, especially when it comes to breast cancer, that the presentation of women, if it's delayed, could lead to higher mortality rate for them. Thank you very much for your time, and I've come to the end of my presentation.
Thank you, Omolade, and thank you for keeping to time. That was a great talk, very thought-provoking. Thank you. Gemma, please can I ask you to set up your slides, and also Mike to do the spotlighting. Thank you, Gemma. Over to you.
Thanks, Arpana. Good afternoon, everyone. I'm Gemma Spears. I'm a Principal Research Associate at Newcastle University within the Healthy Ageing and Policy Research Unit. I'm going to be talking today, I'll talk through some headline findings of some recent work that we've been doing in HAPRU on unpaid care. And the work that we did was not specific to women, but for the purpose of this webinar, I'm going to look at some of these headline findings through the lens of women's health. So first, when I talk about unpaid care, I'm referring to the help and support that people give to friends and family members that is not paid and is not part of an employed role. There are thought to be around 5 million people in the UK providing unpaid care, and about 1.5 million are providing more than 50 hours of unpaid care on a weekly basis. So there is a consensus that unpaid care is highly gendered. For the most part, unpaid care tends to be provided by women. So data from ONS, for example, shows that females are more likely to provide unpaid care up until around age 80, at which point we see a shift towards men being more likely to provide unpaid care. And the ONS also have a metric called unpaid care expectancy, and this is the average number of years of remaining life spent providing unpaid care. And unpaid care expectancy is also higher for women than men at ages 15, 50 and 65. So at age 15, for example, women can expect to spend 7.6 years of their life providing unpaid care, while for men at age 15, it's 5.3 years. Now, over time, this gap does narrow, but even so, even by age 65, women's unpaid care expectancy is still higher at 2.1 years compared to 1.9 years for men. And women are also more likely to be providing care to more than one person, and that might be, for example, an adult child. And this is sometimes known as sandwich caring. So in addition to being more likely to be providing unpaid care, women are also more exposed to material disadvantage over the life course. And this might be due to, for example, lower rates of educational and labour force participation, which will have a cumulative effect over their life, for example, with pension contributions. And obviously, this isn't the case for all women. There is a socioeconomic gradient at work here. But when comparing between men and women, current cohorts of old women in particular tend to be more at risk of this material disadvantage because of those reasons I've just mentioned. And typically also women will live longer, but they will live longer with more disability. And as we know, disability itself is a key driver of economic insecurity. So the way that I see this is that for women, there's this intersecting triangle of disadvantage, unpaid care, and poor health. And after I talk through some of the findings next, I'm going to refer back to this triangle. So in our programme of work on unpaid care in the Healthy Ageing Policy Research Unit, we've been trying to answer 4 key questions. So the first question was around understanding the consequences of unpaid care for older people and by older people. And we wanted to do a bit of a stock take of current evidence on UK carers and better understand what happens when people provide unpaid care, what are the consequences, and who is most likely to suffer adverse outcomes. So we did a scoping review of UK evidence, and from this we see a pattern of evidence that unpaid carers are more likely to experience poor economic outcomes such as patchy employment and financial insecurity and fewer pension contributions. And this is more so the case for female carers, single carers, carers in poor health, carers experiencing financial difficulties, and carers in lower paid occupations. There was also some evidence that carers are more likely to experience worse health than non-carers. However, just a note of caution here, the link between caring and health is complex and not as straightforward as I'm necessarily making out. Our second question was a what works question, and we were interested in looking at the state and scope of evidence about what works to support carers and understanding what sort of interventions have been evaluated and what sort of outcomes have been evaluated in this evidence. And when we looked at international evidence for this question, we found that there's a disproportionate focus on trying to understand what works to support carers' mental health. And there's far less evidence about what works to support carers' physical health and their financial and social well-being. Now, these evidence gaps might not sound like such a big deal, and it's not unreasonable that there is a focus on understanding what works to improve carers' mental health. But given that women are especially exposed to material disadvantage and that they are more likely to experience greater disability in later life, these evidence gaps are actually quite critical. And it's really important for us to know how we can best support carers' physical health and their financial and social well-being. So then we wanted to know a bit more about how unpaid care is patterned by wealth. And so my colleague, Laurie Davies, and the team did some analysis of ELSA data. And this showed that financially disadvantaged unpaid carers in their households are more likely to experience loneliness. They're more likely to experience poor health and poor quality of life. And the poorest carers are also more likely to be over 66 years old and live with a person that they're caring for. And then more recently, we've been exploring regional differences in carers' health. I can't say too much about this work because we're still refining it and it's ongoing, but it does look like regional differences in carers' health may be more prominent for female carers than male carers. So the narrative across these findings is that unpaid care should be a public health concern and it should be a priority to address because it is linked with adverse outcomes and even more so for the most disadvantaged in society. And I would argue that this is an important narrative for all people providing unpaid care, regardless of whether you're a man or a woman. However, for women providing unpaid care, this message does feel especially urgent. So going back to that triangle that I referred to earlier, women are already expecting to live with more disability and more poor health in later life, and they are already more likely to experience material disadvantage than men over the life course. And this is before you add in the health and economic burdens of unpaid care. So I think a key takeaway is that we need to find effective ways to prevent poor health and economic adversity of carers. In doing so, I think it would be important for anyone providing care, regardless of whether you're a man or a woman, but it would represent an important investment in public health, specifically for women, given their greater risks of poor health and economic insecurity. But critically, we do need to ensure that the most disadvantaged women providing care can access and benefit from such support. So we're not finished doing work on unpaid care. There'll be more to come. And I've just popped some questions here, which I guess these questions are my thinking on this and trying to think, well, where can we go with this next? But I've put them here because I thought it might be useful just to get, if anyone here is interested in unpaid care and they've been doing work on this, I'd be interested to hear your thoughts about whether you know of any examples of good practice on supporting health and economic outcomes for women providing unpaid care, and what a good preventative health approach might look like. I will pop these questions in the chat as well. Before I finish, I do want to add a quick cautious caveat. I have whizzed through the findings of this work for this 10-minute presentation, and in doing so, I have missed out quite a lot of nuance and complexity, and there is a lot of nuance and complexity to these findings. So it is worth reading the outputs of this work if you're interested in unpaid care. You can find them using these QR codes, or alternatively, if you want to chat about this, feel free to get in touch and we can arrange some one-to-ones. Thank you for listening.
Thank you so much, Gemma, and thank you most importantly for keeping to time. You've given us some really great thoughts for the Q&A, and whilst we get our next set of slides up, I just wondered if we could do a plug for the meeting chat. Please do post your questions in the meeting chat. The speakers are very keen to hear from you, and I can see that Liz is ready. So thank you so much, Liz, for coming here today, and I'll hand over to you. Thanks, Liz.
Thank you for inviting me to be part of such an interesting and inspiring seminar. I'm Liz Thomas. I work as a nurse at Urban Village Medical Practice in Manchester, and I'm talking today about how we're putting the needs of homeless women at the heart of our Women's Health Hub. I'm going to briefly set the scene for you with some context, and then focus in more detail on our service and what it's meant for some of the women that we're working with. Just lost me. There we go. Right, so we've all really welcomed the recent interest in women's health, and it has highlighted the difficulties experienced by many women, even quite privileged women, in accessing care for quite common concerns. Our practice is Manchester's Women's Health Hub. We're a city centre practice. We've got a young population. We do a lot of cervical screening, contraception, sexual health care. But the question that I'm exploring here today is, how do we ensure that the kind of healthcare that Davina's championing for is also reaching homeless women who describe barriers to just registering with a GP, lack of phone or an address to organise and receive appointments, let alone managing all those other key competing priorities in life, addictions, unstable mental health, the impact of trauma and repeated sexual violence. Many of the women that we're working with are in very unsafe relationships with controlling partners or pimps. They make it really hard for them to access healthcare. We're often dealing with a legacy of trauma after children have been removed. Rough sleeping women have got a life expectancy in their early 40s. That's a stark illustration of the challenge for women's health hubs, who really need to be asking, how can we ensure that we give the most access to the women who need it the most? That's the kind of question that we've been exploring for many years at Urban Village Medical Practice. We're an inclusion health city centre practice. We've been providing accessible primary care and shared care drug services to people experiencing homelessness in Manchester for over 25 years. I'm going to give you some detail now of how we're making it easier for homeless women to receive healthcare. So we're an integrated service. First and foremost, we're a GP practice, so we're providing flexible access to full GP registration, daily flexible GP and nurse clinics for homeless patients. We've got an outreach van. So on the outside, it's a plain and ordinary van. Some people say it looks a bit like a prison van. On the inside, it's a fully equipped NHS clinic. So we've got a regular outreach timetable, taking that healthcare out to where homeless women are, in homeless day centres, hotels, women's hostels, and onto the streets. We've got an empath team, Manchester Pathway team, who are going in daily to the MRI, Manchester Royal Infirmary, doing daily ward rounds, identifying people who are homeless and doing discharge planning to optimise their health during their stay. And the fourth element to what we're doing is we've built very close relationships with a range of other partners. So, for example, working closely with services like infectious diseases, GUM services. We can provide on-site management in primary care for conditions like HIV, hepatitis C, syphilis. We're maximising what we can achieve in one place and ideally in one visit. So focusing a bit more on our outreach, people always say the same thing when they come into our van. They say, wow, it's just like a proper clinic. And it is a proper clinic. We're not signposting into healthcare, we're taking healthcare out to provide opportunistic access. So when you come and see us on the van, you can have your weight done, your height, your vaccines, your blood pressure, blood tests, ECG, spirometry, smear test, sexual health screening, contraception, including emergency contraception, or having an implant fitted or replaced. We find that people are sometimes much more relaxed in environments where they feel more familiar, like a day centre or a hostel. And we nurses don't mind, but some women much prefer being able to have a shower before a procedure like a smear test. So being able to deliver those services on outreach in hostels and day centres with showers works really well. Our uptake of smears for our homeless women matches the city centre average. We're literally meeting women where they're at. We're exploring their priorities. We're bringing care to them to access at a pace that feels manageable. I'm going to introduce you now to 3 women who've used our service and tell you a little bit about their experiences. So I first met Sonia in one of the homeless day centres. She was accompanied by a very controlling partner who was reluctant for her to see me alone. Obviously, that raised concerns, and the day centre supported me to see her on her own while he was in the shower. I was able to address my safeguarding concerns with her and set up an appointment for her with an IDVA, an independent domestic violence advisor. She said to me that she'd pretended to her partner that she was going to have a smear test in order to justify to him why she was seeing me without him. She was due a smear, and I suggested to her that we did her smear test. What, here, now? Well, yeah, go on then. So we did her smear test for her. We also identified that her contraceptive implant had expired, so I could get that replaced for her at the same contact. I met Beth on street outreach. She was rough sleeping at the end of a very abusive relationship. She was drinking heavily. She was very low in confidence and had a lot of shame around her appearance. I couldn't come and see you looking like this. She was experiencing quite significant genital discomfort, and I was able to offer her the option of being examined on our van, which was parked very discreetly on a side street. She took up that offer, so I could get her smear test done for her, her sexual health screening, and that was positive for syphilis. So I could support her to access syphilis treatment at the GUM clinic, and we continued that treatment in primary care. Beginning to come into primary care meant she could also start working with the GP around her mental health. I met Susan on outreach on our van at one of the women's hostels. She was sex working, smoking a lot of crack and heroin, engaging very sporadically with health and drug services. Her priority when she came to see me was that she'd run out of inhalers. She had very poorly controlled asthma, so I could get that sorted for her and also get her flu and COVID vaccines done. I saw her a number of times over the next few months. We got a full sexual health screening done and I treated her for 2 sexually transmitted infections. Getting to know her, she talked with a lot of sadness around her children who'd been removed from her care. She expressed some curiosity in the contraceptive implant that I'd fitted for another resident in her hostel. And she said she was starting to wonder whether at this point in her life that would be a good option for her. So we could get that fitted for her. We did that the same day on the van, parked up outside her hostel. And when I saw her next, she said to me that she felt really good about that decision. She said, "This is the best decision I've made in years. And I wouldn't have done this if you hadn't made it so easy for me by coming here." So I'm going to leave you now with our takeaway messages for what we think is important designing healthcare for homeless women. So we are a regular offer. We're not a random pop-up. We're there week in, week out. We're a stable workforce. We're a consistent service, even for someone who's moving around a lot. We're offering that continuity. So same van, same place, different settings, same team. We're a consistent service. We're offering continuity of that relationship. We're a mobile clinical service. So we're taking healthcare out. We can be opportunistic. We can respond in that moment when a woman says, "Liz, if I don't do it now, I'm never going to do it." We're a holistic offer, so we're not just providing sexual and reproductive health, although those are often priorities for the women that we're working with and one of the reasons why they come to seek us out. We've built these very strong partnerships with other services, so both voluntary services like the day centres, which are all charities, and statutory services. We're really seeking to maximise health outcomes. On-site shared care drug services create great opportunities for us to engage women together so we can address multiple needs at the same time. We can coordinate care between services. So, for example, coordinating a methadone script with syphilis treatment. Empath team have been able to advocate for women as hospital inpatients to receive interventions like colposcopy or having follow-up around sexually transmitted infections. We're a well-equipped service, so we're equipped with more than just this great clinical mobile van, but we've got the robust processes and governance that underpin what we're doing as nurses on that setting. We're supported by the expertise of a whole GP practice and a very experienced homeless health team. So when we're dealing with complexity on outreach, which we often are, we've got that backup as nurses. So to conclude, I think what we're showing here today is that so-called hard to reach women are not so hard to reach after all when you design a service around their needs and work with the right stakeholders. That's a good foundation for all women's health hubs. So thank you very much. You can see our website here and also contact details for the team if you'd like further information.
Thank you so much, Liz. That was a phenomenal presentation, really demonstrating how you're out there and doing that such key activity for those people that need you the most, and yeah, not leaving anyone behind. So thank you, Liz. We're so pleased to see you here. Thank you so much for presenting your fabulous work, and I love the title. So thank you so much, and over to you.
Hello everyone, welcome to the Sign Health presentation. Here to talk about the Still Sick of It report. My name is Kirsty. I'm a campaigns officer here at Sign Health. You'll also see my colleague. Her name is Philippa. She's the interim director of comms and campaigns. Still Sick of It is a campaign that we here at Sign Health have launched recently. I'll give you a little bit more information about the background and context and what Still Sick of It is and why we've launched it. The Sick of It report was something that was released in 2014 by Sign Health. This report looked into investigating deaf people and their access and their engagement with healthcare services. It found that within the deaf community, many deaf people actually suffered from a lot of preventable and potentially life-threatening illnesses. We'd say preventable because they are not getting sort of access to the healthcare. They're also experiencing a lot of misdiagnosis and also poor or incorrect treatment through lack of communication support, communication barriers, not providing an interpreter or a lip speaker, or any number of communication needs that they have. We found that 45% of deaf women actually go to a GP practice to make an appointment because they can't access the phone lines that lots of GP surgeries install to make appointments. So they have to go there themselves. 45% is quite a high number. And then 56% of deaf people actually don't even engage with healthcare services because they don't have that communication need that they have. They don't have an interpreter. We find that lots of deaf people actually do need to engage with healthcare services, but they don't. You know, whether deaf or hearing, it's so important that we look after our health. And if there's something that we can't access, then how can we look after our health? In total, all of these barriers that deaf people face, the misdiagnosis, etc., it costs the NHS £30 million a year. I mean, this is a cost that can be prevented by working with organisations like Sign Health to make sure that these barriers that deaf people face are reduced or eliminated. The AIS. I don't know if any of you know about it. I hope you do, but if you don't, hopefully you can take this away with you today. So the AIS is the Accessible Information Standard. It's been in place since 2016 and is something that the NHS should follow. There are 5 steps to it. The first one is ask. This means asking the patient what their communication needs are. The second is record. Obviously, it means putting it into their systems, whether it's at the GP or various systems. The third one here is flag, and it just means that when a person with a communication need comes to reception, it comes up on the system, it's flagged that this person needs a lip speaker or needs an interpreter. And then we have share and then act. So these are the 5 steps. There is a very clear procedure that the AIS sets out. We at Sign Health partnered with the RNID, which is the Royal National Institute for Deaf People, to create a huge joint survey focusing on healthcare access. We found that 70% of deaf people have never been asked by the NHS what their communication preferences are, meaning only 30% of them have been, which is a very, very low number. 1 in 3 healthcare professionals that were surveyed had no idea about the NHS, which is quite a large pitfall because imagine a deaf person arriving for their appointment and the professional they're seeing doesn't even know about the Accessible Information Standard. How can they ensure that their deaf patients' rights are being met? And then 2/3 of BSL users have requested interpreters, requested communication support, but have been denied. So imagine going to an appointment where, you know, it's vital for healthcare, or it doesn't kind of even matter if it's a serious health condition or not. There should be full access for all healthcare appointments. Hearing people going to the doctor with a worry about their health can communicate that to their doctor smoothly, but a deaf person had that added worry of whether they'll be able to even communicate with their doctor. It's an added burden. Here we've picked out some quotes from deaf women from the survey and the report that we created. There's lots of themes that have come up again and again. One of them talks about independence and dignity. So she says, if there isn't access, if there's no allowances for my communication needs and no interpreter, you know, where does my independence and dignity go? Another talks about having to take her mother and other family members, and how embarrassing that is to have their family member hear everything that goes on in that private health appointment. So they'd much rather go on their own. And this person specifically says that if a mother isn't available to go, she often delays the appointment. But obviously with some serious health appointments, it cannot be delayed. Another woman here talks about having to take her husband and relying on her husband, which is very disempowering. And also feeling like a burden to have to do that, and avoiding healthcare appointments because of that feeling, because the access she knows won't be there. We have 3 stories that have been collected through this survey process. The first one here is Gloria. Gloria's husband had been diagnosed with cancer. The interpreter provision through the AIS actually covers deaf people who are carers for patients. So under this, Gloria had the right to have her own BSL interpreter. So at the time the two of them went to a doctor's appointment, the doctor came to deliver the news to her husband that he had cancer. Gloria obviously had no access to this information because there wasn't an interpreter. And so her husband had to tell her, and she was the last person in the room to actually access that information. After a while, her husband did end up passing away. And it's such a sad story because Gloria should have been, fully empowered to be there to support her husband, to access the information, to ask her own questions of the doctor. But in the end, she had to rely on her husband to deliver that news. It's so inappropriate, and it shouldn't have happened. Here we have Dorothy. Dorothy had given birth to a beautiful baby and had laid her next to the bed because she was absolutely exhausted after giving birth and had fallen asleep. The midwife then came into the room and started speaking to Dorothy. The midwife didn't know that Dorothy was deaf. We don't know why. So she shouted at her. She kind of tried to wake her up, but Dorothy didn't wake up from that. And the midwife, not knowing what to do, slapped her across the face. She slapped her to wake her up. And I feel it kind of doesn't matter if you're deaf or hearing. I feel getting slapped in the face to get woken up is not really appropriate. So Dorothy obviously woke up in pain and shock. And through this story, she said, what I'd really love to see in the future for the NHS is the changes I'd love to see is that, on those whiteboards that you have on the top of behind patients' beds that maybe show their name or show that, for example, if they'd had surgery, that they're nil by mouth or that kind of thing. Dorothy thought that, if there is a sign there that just says, I'm deaf, I'm a BSL user, I'm a lip reader, whatever. I think any NHS professional or any healthcare professional who maybe haven't looked at the chart can see that information there front and center. There's no ifs, no buts at that point then, because she feels that she wouldn't be treated like this if they just knew that she was deaf. Also, another thing to consider is that the word deaf, actually, it covers deafness, but we need to remember it includes so many different identities. We have deaf women, we have, deaf Black women, deaf Asian women. These intersectional identities are all things that layer on top of deafness. And so when people engage with the NHS, they are there. These are people who have lived experience of systematic bias, of the kind of judgment and prejudices that are aligned to their identity. So when you see deaf people, you need to remember that deaf people are part of every community. Every community has deaf people in it. And so the lived experiences of those communities are simply laid on top of the experience of being deaf. Here we have Rachel. She had also just given birth, but unfortunately afterwards she became quite unwell and had to stay in hospital for 2 weeks. Across that 2-week period, the period of 14 days, she only had 3 interpreters booked over that entire time. So through all the medical issues, all the discussions she only had access 3 times. So all the other times that the doctors came to speak to her, she didn't have full communication access. So now we get to Still Sick of It. I think the campaign aim makes it really clear. We are still sick of this. Since 2014, in the last decade, over a decade, it feels like nothing has changed. We are still sick of it. No more excuses, no more barriers. Should we be denied our communication access? No, it's an absolute right. When the proper access is provided, here we have two quotes here. One person felt that they were able to access the healthcare on their own, could understand everything that was said to them and understand their treatment. The other example here is a person who had breast cancer, and they felt it was really good having a lip speaker with them because their family couldn't be with them at all times through the treatment. So it was full access and having a person with them. Some excellent examples. So how can you all get involved? You can talk to your MP. So we actually have a template letter that you can use. If you look at our Still Sick of It website, you'll find a template letter on there that you can send directly to your MP to encourage them to improve health access for all deaf people. You can also talk to the NHS if you work within the NHS or you're in dialogue with them. Introduce them to Sign Health and say that we're able to collaborate with them on sort of deaf awareness and increased access for deaf healthcare. We would love to be involved with them in developing new resources, because it means that deaf people then are at the start, at the grassroots of developing this. We don't want them to sort of waste money on creating resources that we then consult on and find to be inappropriate. Also, you can also share our content. We're on all the socials, Instagram, Facebook, etc. Just at Sign Health on all of that. If you share our content, the more people that see it and view it, the more people then become aware of the issues that deaf people face and get involved in that campaign for change. Thank you so much for watching. You can scan this QR code where you'll find more information about Sign Health, our Still Sick of It report, and also the template letter to your MP.
Wow, what an amazing way to end our presentations. But you've all given us a great set of food for thought on how to work together better. So I'm just going to take some of the Q&As in the chat. Omolade, thank you for starting our session off. With your research background and also the systematic review, what's the single key thing that you think we as a community should be focusing in on?
I think we should do a lot more work with engaging with community peer researchers. And that's just not as a token thing or just working with the people we already work with. I think we need to diversify the pool of people we work with. And I believe that the more we engage folks that are affected by the problem in the research or not, that we would be able to engage more, really, because research, as you can imagine, is very elitist, is not everyone. And even our PPI is like people with lived experience. I think we need to do more work with people that do not have a lived experience of the problem, but they are part of the community we are trying to research. And I believe that we should go beyond outreach to power sharing. So we need to engage beyond just telling them doing PPI is good, is a first step, but it's not the whole thing. And I mean, it's very complex, but I think that's where I will start from.
Thank you, Omolade. Gemma, I know you've been answering some of the Q&As, but I just wanted to pick out your comment to the team, really, about advocating unpaid care as a social determinant of health. I wonder if you'd like to expand on that and how we can come together to support you for that very important step.
Thanks, Arpana. Yeah, I mean, we did first advocate this a few years ago when we worked with Public Health England, and there's a lot of evidence that being an unpaid carer is linked to poorer health. So why shouldn't it be considered a determinant of health? And given that, I think it's safe to say we're going to see a lot more people providing unpaid care. Potentially, we don't know what's going to happen with the social care service. We've got a growing aging population with more complex needs, and a lot of that burden is going to fall to friends and family. And so I think we need to make sure that we push it to the centre of discussions around healthy aging and public health, and bring those two together. In terms of what can be done, oh goodness, I'm not sure. I think there's probably more linkages to be made. I used to work in a very social science, social policy setting before I shifted into the more epidemiological public health space, and a lot of the caring work is in that more social policy, social administration space. And I think perhaps there's potentially work to be more interdisciplinary as a research community, and to pool our strengths, really. And that might be one way of pushing this up the research agenda.
Thank you, Gemma.
Thanks,
yeah,
Arpana.
let's do that. Liz, lots of comments in the Q&A, and thank you for that, opening our eyes to what's achievable if we go out there rather than expecting people to come to us all the time. I think Colette and I felt the same way, that you just showed in your presentation, that unmet need that we have. And so I'm sorry, this is such an impossible question to ask you to answer, but what would you say your top priority is here?
I was thinking about your question you put in the comment, and I think you were asking about gaps in the evidence base. And I think what's really quite overwhelming in the field of homelessness and healthcare is that the evidence is very robust already. We've got overwhelming evidence about the relationship between homelessness and health inequalities, and how women are particularly impacted. The life expectancy data really couldn't illustrate that any more clearly. And we kind of already know how to do this. We've had periods in our nation when, you know, the political will was there, homelessness was halved and stayed that way for quite a long time. We kind of know how to do it. Homelessness isn't inevitable. There are lots of countries that have taken, you know, systematic, you know, approaches to developing appropriate, you know, systems and policies. So we kind of know it already. I think I would say that, you know, really, were we to sort of take up such an approach again, it is about that gender aware lens. And I think in particular, a lot of the women we're working with, one of the overwhelming things that they talk about is just how dangerous their lives are, how incredibly unsafe and terrifying that experience of homelessness is. And that's not just rough sleeping, that's women who might be in hotels or hostels. They really don't always feel like very safe environments. And I guess if we were gonna, you know, think about gaps, then, you know, that's something to really explore. And I think there's some really great work being developed in really kind of how we can learn from women with that lived experience and take their voices into how we're kind of as a city, you know, thinking about addressing the needs of homeless women. And, you know, those stories of ongoing abuse and violence are harrowing. And I think, you know, we've almost all got a duty to kind of hear them, really, to really understand that the ways in which women in particular experience homelessness.
Yeah, thank you, Liz. And I know that Kirsty and Philip have had to leave us, but one of the key things for all of your talks is let's not be here in 10 years' time with these terrible statistics. And so I think just hearing you all and the phenomenal work that you're all doing and thinking about how we link that up is really part and parcel for the team who've brought together these webinars. I did want to say a huge thank you to Jane and the team. We've got our next set of webinars coming up. Please, if you are one of our speakers, please use the chat to answer the questions we weren't able to go through today. But most importantly, please keep in touch. And Mike, I'm going to ask you if it's possible to download the chat so that our participants and our speakers can see all those great questions and resources that we have in the chat. So we're looking forward to seeing you next week, where we'll be talking about reproductive health and maternal well-being. The series of webinars are from our Biomedical Research Centre, our Clinical Research Facility, our Policy Research Unit, as well as the Health Determinants Research Collaboration and other projects. We're very grateful to you all for joining us on this first seminar, and what a great start. We'll be having more events after the webinars, including face-to-face, that will go on, and we hope that by being together we can be stronger, putting women's health really onto the map of all of the work that we're undertaking is there in front of policymakers, research funding bodies, and most importantly, the children and women that we serve. So thank you so much to everybody for taking part today, and apologies for running over, but those were fabulous talks. Thank you so much.